I'd like to introduce one of my old partners, Dr. Rick Ware, who is here to join me and discuss some of the changes that we've seen in our anesthesia practice over the years here in Everett. Rick, why don't you tell us a bit about how things were when you came to town?
Well, I came from Virginia Mason. Okay, I take it we're stopped.
We can do that one more time. Let's start.
I'd like to introduce one of my younger partners, Dr. Rick Ware, who is here to join me and discuss some of the things that he has seen in the changes of the anesthesia practice here in Everett, and tell us a little bit about how things were when he first came to town. Rick?
Well, I came from Virginia Mason, and I guess it's probably true in any training facility, but Everett was considered out there, St. Elsewhere, and not quite as bad as the Aberdeen Express that we used to get on the weekends when people would get sick on the peninsula. But when I came up here, I was really amazed at the quality of the medical staff. It was a tremendous medical staff at the time, and still has been. That's one of the things I think that's been constant. But when I came to town, the machines that we had were not so different than what I had at Virginia Mason, but there were some differences. There were a few things. I remember Maxine Reed was telling me that when she came to town just a few years earlier, they didn't even have EKGs in all the rooms. So we wouldn't think about doing anything, including probably a local nowadays, without having an EKG on. The other thing that I thought was kind of interesting, we added pulse oximetry here to keep track of how well patients were doing with their oxygen levels. And when I was at Virginia Mason, the thing I was taught as a resident was if a patient could talk to you, well, they're just fine. But it turns out when we got the pulse oximeter, you kept knocking the machine on the side going, that can't be right. That's, there must be something wrong with this because that oxygen saturation is not so good after all. So I think some of the patients that didn't do well, so in those earlier days, it was probably that we didn't have something that where we could really
Yes.
tell how well they were doing. So I suspect that from the time when I came, it was probably new technology stuff that was happening from
Yes.
your world.
I noticed that we think that things aren't changing in our practice from day to day, but if you take the 10-year increments, then you find that things really have changed. And one of the things I've noticed since I've been doing locums work and traveling around the country, that the level of practice in Everett is very high. I think the service provided here exceeds all the places that I've been, and certainly a lot of the places are not as far advanced as the practice here in Everett. So that made me feel good.
Yeah, it's always strange, and I totally agree with you. I think that the practice of medicine in general has been good here, but the quality of the anesthesia group has been really very good too, despite the fact that, as you mentioned earlier, we've been sort of a farm club and lost any number of people. Gosh, just in the last few years, Tom Stibbins and Rich Okamura and Rolf Olsoy and just many other people that have left our group and gone down there. But despite that, I think we've maintained a pretty good quality level here. I do remember one story. I was new to town, and I went in to start a case over in room 1 over at what now we call Pacific, but was the old Providence. And I went through, and of course I was so careful to check everything on the machine. I took the bag off when I hooked it up and tried the ventilator and everything. Took the bag off and put it back on the machine. Got the patient in, got the patient asleep, put the mask on. I just couldn't ventilate. I thought, oh my gosh, it's some sort of allergic reaction or something's going on. Well, of course, when I switched the ventilator, that was the old machines that you switched the ventilator back or forth. I hadn't switched it back after being so intent on checking the machine out. I never did put it back in the correct position. So I had to call my partner in. This is like the third day I'm in town, I had to call my partner and I said, well, I can't ventilate this guy. I think there's, I think he's got laryngospasm and everything. He looks over and he goes, turns the valve and walks out. And I'm gone. I am gone. I'm not going to make it. And I certainly didn't think I'd make it 25 years with that kind of a start. But yeah, the equipment didn't even have alarms on it.
No.
Really, in those days.
No, there were no alarms, and our monitoring things were rather rudimentary. Of course, we used a lot of not pulse oximeter, but we used the precordial stethoscopes a lot in the old days,
Right,
and esophageal stethoscopes and those, and we listened to the heart. Well, I don't know, the heart's still beating even when there's oxygen saturation is 60, so that didn't really help a lot, but we tried our best. And actually, talking about oximeters, they're really an old system. We had those in the late 1950s, but they didn't have the little computers that did all that calibration and measured your pulse, and then had a different sound as your saturation went down and so on. We had to put them on the ears, and we used them mostly for chest cases where we were doing single lung ventilation, and we wanted to make sure that we had adequate saturation when we had the patient breathing on just one lung. But when Dr. Weiss and Dr. Mason came to town, the anesthesia in the town consisted of intravenous pentothal, halothane, nitrous oxide and oxygen, and a succinylcholine drip. And
I've probably done succinylcholine drip once or twice in my practice.
it's still a useful technique when you're looking for a real short-acting relaxant, and nowadays they take the short-acting muscle relaxants away from us, and we have those periods where you just want a few minutes of relaxation, and all the other drugs last too long. And
Well, if we were in Europe, we could use Rocurium and Sugemadex.
That's right.
And just instantly reverse it.
We'll eventually get it here in the United States.
But you think about when I came to town, even you look at the practice now, and how many medications do we have that we routinely use that were on the formulary then? We had Forane, but nobody uses Forane anymore.
No.
We had Halothane. It's not even
Nobody
on the
uses
machines
that
anymore.
anymore,
Succinylcholine, which we still use to some extent, but mostly it was Curare.
We had Curare and Curonium.
We don't
and
use those anymore, very rarely.
I don't think Curare is not even in the. I don't know if it's in the formulary anymore. Probably
Penethol's
not.
back in the back of the drawer somewhere. Where
That's
you have
right.
to mix it up now. That used to be our mainstay drug. If you went through it, I'll bet maybe 15% of the drugs and things that we do now are the same as they were.
Well, the other thing that has changed is our patient load, our patient selection has changed. When I came here to practice, a lot of the people we operate on today wouldn't even think of bringing to surgery. We have certainly a much sicker, older population than we used to have, and it's been quite a change. However, I always say that it's not the 90-year-old people that you have to worry about, because if they live to be 90, they're usually pretty tough. It's those guys that are overweight and don't exercise, and they're about 60 years old, and they're just a time bomb waiting to go off.
Right.
And I think I worry more about them than I would do about the 90-year-old lady who's been just tougher than nails.
Yeah, and I think that, but if you look at the monitors we have now and the way things have evolved, end-tidal CO2s and end-tidal agent monitors, we had at Virginia Mason, it was really technologically superior. They had a machine that was probably a third of the size of this room, about the size of a small hall bathroom, and this thing was huge. Had all these tubes that went up and into the ceiling and then down into the operating rooms, and that's where they did the end-tidal monitoring of their gases.
Yes.
To see how much anesthetic you were giving as opposed to what you dialed in. And of course, in those days, it was 5 liters for halothane and 3 for enflurane, right?
Well, and nowadays too, a lot of the hospitals are getting the computerized record keeping, so it records all of your end-tidal gas amounts continuously throughout the case, so you don't have to sit there and write all that down, which is good and bad. If you sit and write everything down, you tend to pay more attention than if some machine is recording it. You can just kind of sit back and put them on automatic pilot and not pay much attention to what's going on. There's a little problem in that, I see also, but it is nice because it does free you so that you don't have to be writing everything down and especially now, since anytime we want a drug, we have to press a little button and type it in and get it out of the machine. And in the old days, we just had all that stuff sitting on top of the stand, and we just drew it up and gave it, and that was it. But now we have a fancy machine that we have to type it in and then hit the button, and then it says that you gave it.
Let's pharmacy bill for it.
And let's pharmacy bill
Sure,
for it.
sure.
To paraphrase one of the popular advertisements, progress can be our most important problem. Well, I'm going to leave Rick to give you some more insight into the practice of anesthesia in this community, and I'm going to head off to Monroe and take care of an emergency.
You'll probably get there before they get it set up.
I will, I'm sure.
Thanks.
Well,
Tom.
they're pretty fast. They're pretty fast. I will.